Welcome back to Clinical Problem Solving. We are on week 5, and we've spent the preceding 4 weeks talking about how to make good diagnoses. And this week we're going to be talking about what happens if you make a bad diagnosis. Our focus of efforts today is mistakes. Again, I want to acknowledge my colleagues and add another one today, Matt Roosevelt, who will be a guest speaker for the second part of Module 5, and I'm sure you'll be excited to see the way he's taken the work we're doing on clinical problem solving and developed a novel way of analyzing cases to help you identify your mistakes and learn from them. So a brief review for Modules 1 through 4. Module 1 taught us about disease-based illness scripts, those memory strategies that experts use to store information about diseases in their brain. And Module 2 talked about how to move us from a patient's history and physical into an analogous structure known as the patient's illness script, with key elements that we have to identify for each patient: the epidemiology, their time course of disease, the syndrome statement, and other important past medical history that might be relevant. We match those two entities, the patient illness script with possible differential diagnosis disease-based illness script, to develop a prioritized differential diagnosis. And we tiered them according to likelihood. Tier 1 being clinically high likelihood, either likely or very likely, if the disease that we're considering explains all of the patient's major findings, and the patient has all of the major or typical manifestations of the disease. That's known as a Tier 1 disease. A Tier 2 disease, clinically moderate or uncertain likelihood, is present if the disease we're considering as an explanation for the patient's symptoms explains most of the patient's findings, but not all of them, or if the patient lacks some of the usual manifestations of the disease that are typically present in our understanding of that disease. And Tier 3 possibility is clinically low likelihood. And that's the case if the disease we're considering really only explains one or two features of the patient's presentation, and if the patient only has a couple of features likely to be seen in that disease. We used a graphic to represent the spectrum of likelihood from very unlikely to very likely, and also added some numbers so that we could use our evidence-based medicine clinical problem-solving strategies and translate pre-test probability into post-test probability. So recalling our tiers 1, 2, and 3, remember we split both tier 1 and tier 3 into two categories, depending on whether or not there was a classic feature present that only occurred in one disease, and that would be a very likely disease, or if there was a feature present or exhibited by the patient that really essentially ruled out the condition. We called that very unlikely. And we used this to work through several 2x2 contingency tables proving Bayes' theorem, and then identified a heuristic that we can use in the clinical setting without getting out our calculators to understand how our pretest clinical probability of disease would be impacted by our post-test probability. And remember, this heuristic, written about in this evidence-based medicine article referenced down here, told us that if you're dealing with a good test, that is a test with a sensitivity and specificity greater than 85% but less than 99%, that these good tests are able to help us move our certainty about the likelihood of a given disease causing a patient's symptom up or down one category. So example, if we think clinically that the patient's likelihood of a given disease is uncertain, a positive test would move it to likely, and a negative test would move it to unlikely, but not all the way up to very likely or all the way down to very unlikely. We also talked about special cases where if the sensitivity and specificity are either or both greater than 99%, those are the situations in which we can conclude that a test could in fact rule in or rule out a disease. So, new content on Module 5. Our goals for Module 5 are to review a case of test interpretation error. Mrs. Triglioni is back with another problem, and she is counting on us to help establish the correct diagnosis so she can return herself to health. We're also going to describe several reasons diagnostic errors occur, and in doing so, we're going to talk about what experts know to be the causes of diagnostic errors, and this involves some work from the fields of cognitive psychology and human systems engineering. It's very interesting, and I hope you'll enjoy it. We'll also make sure that by the time you finish this module, you'll be able to understand the concept of cognitive biases and identify some that are commonly used in the clinical environment. And then Dr. Roosevelt will walk us through a strategy known as problem mapping that he and his colleagues at San Francisco General Hospital have developed, employing a lot of the work we've done in the past 5 weeks here to help people learn from their mistakes in diagnosis. There are 2 really terrific books for people who are interested in this work after reviewing this module. You don't need to read them in order to do the homework, but anyone who's got more than a passing interest in this might find these interesting. The first is a book known as Human Error. It was written about, I guess now about 20 years ago by James Reason, and really works through different causes of medical error. And the second is a more recent book by Daniel Kahneman in the lay press known as Thinking Fast and Slow, and that talks a lot about how we make decisions in a really dynamic environment. Both of them are very interesting. This is a little bit easier to read, but if you're interested, I'd recommend both. Okay, so Mrs. Triglioni is back with a new problem. After your astute diagnosis of her probable pulmonary embolism was confirmed through a series of appropriate diagnostic tests, she was admitted to the hospital with that diagnosis and started on heparin therapy for the pulmonary embolus. About 30 hours or a day and a half into her hospitalization, in the middle of the night, Mrs. Triglioni got up to use the commode, strained to have a bowel movement, and became acutely short of breath and very dizzy, described as room spinning continuously. She said that the dizziness or vertigo was worse when she opened her eyes and turned her head, and she was unable to get comfortable regardless of what position she laid in. When she opened both her eyes, she complained of feeling double, and in addition, she says that her right arm feels very wobbly, and she was unable to support her weight on it when she tried to reposition herself after returning to bed. So hopefully you're noting the really key new issues in Mrs. Triglioni, worsening shortness of breath, new complaint of dizziness, some double vision when she opens both her eyes, and a problem with her right arm that's difficult to articulate. So let's look at her physical exam and add those to the problem list that hopefully you're keeping as we're moving through this problem. So on physical, her blood pressure is slightly elevated, heart rate slightly elevated, and her respiratory rate is elevated as well. Interesting, her pulse oximetry is down to 85%, so pretty dramatic drop compared to what she had been right before this episode occurred in the hospital. She is incredibly uncomfortable, continuously vomiting, and she's holding her right eye closed because she said when she opens it, she has double vision. In her lung exam, we hear a pleural rub in the left posterior lung field. Interestingly, that correlated right at the area of chest pain that she had had when she presented. Her cardiovascular exam shows a non-displaced point of maximal impulse and normal heart sounds, except that her S2 has an increased pulmonic component, and there are no murmurs present. Abdomen is normal, and the leg continues to be markedly swollen to the level of the thigh with what's known as dependent rubor. It turns red when her leg is dangling. Obviously, it's clear that she's had recent knee surgery, and there's no evidence of infection there. Her eye exam is somewhat difficult because she keeps vomiting every time she opens her eyes, but it's clear that she has upward beating nystagmus in both eyes. We're unable to assess her visual acuity and her visual fields, and some of her cranial nerves can be tested and are intact, but we really can't assess cranial nerve 7 because of her symptoms. A right pronator drift is present in her arm. Reflexes are attacked in arms and legs, and she can't walk because of her immobilized leg, but when she sits on the bed, she falls to the right side. She is not a happy person. So let's look at a processed problem list. Acutely worsening hypoxia accounts for the increased respiratory rate and the drop in the PO2 and describes the time course over which it presented. Pulmonary hypertension is how we would process an elevated P2 in this setting. Vertigo, it's not lightheadedness, it's a specific type of dizziness that describes a rotary component to it, and she has articulated that clearly. Diplopia or double vision, nystagmus, upward beating, we could actually add that. Monoparesis in the right arm, that pronator drift, indicates there's some weakness in that right arm, particularly in a right-handed individual. Truncal ataxia, when she sits on the side of the bed, she falls over. It's not related to standing. And of course, prior evidence of a DVT on her exam. Let's compose Ms. Triglioni's patient illness script. Epidemiology, this is a 48-year-old woman with a DVT and a pulmonary embolus. So this is an interesting feature here. We are considering DVT and pulmonary embolus to be an epidemiology. That is a exposure, a risk factor, or another disease that might be related to the acute presentation. So we want to put it right up front because it'll help us analyze our signs and symptoms in the context of her illness, which I think is critically important. Time course we've described as acute. Some people might even call it hyperacute. She was fine 1 minute and the next minute she wasn't. And then a syndrome statement, hypoxia and pulmonary hypertension. So if you're thinking physiologically to disease-based illness scripts, that might be giving you a clue as to what might be going on. And a central nervous syndrome characterized by vertigo, diplopia, nystagmus, monoparesis, and truncal ataxia. This is actually evidence of summative processing, right? So central nervous system syndrome was recognized by the examiner as being present because this constellation of signs and symptoms has to have its origin in the central nervous system. So this represents very high-level processing by the individual who saw her. And then, of course, the other history is her surgery 3 weeks ago is relevant to this presentation because it does give us a little bit more flavor about her pre-morbid condition. So tiering, her tier 1 diagnosis, recurrent pulmonary embolus with paradoxical embolus and brainstem stroke. Let's see why people describe that. Well, the hypoxia and the pulmonary hypertension suggest a recurrent pulmonary embolus. Why do we think it was recurrent as opposed to just an extension of what had been present there? Because she was fine, got up, used the commode, and acutely dropped her pulse ox to 85%. So something acute happened, and this individual was considering a recurrent pulmonary embolus. Paradoxical embolus, not a common complication of deep venous thrombosis, but it would be an explanation for why somebody has a recurrent thromboembolic event and then a central nervous system event. And that implies, of course, that there is a shunt within the heart through which this embolus is moving. What about a tier 3 diagnosis? And we'll see some of the physicians considered these options in the care of Mrs. Triglioni: benign positional vertigo and Meniere's disease. Benign positional vertigo we'll talk about in a couple of minutes. Certainly explains the vertigo, but cannot explain almost anything else. And Meniere's disease, again, explains the vertigo, but we're lacking hearing loss, which is common in Meniere's disease. It doesn't occur acutely, and it can't explain almost any of these other features that seem really quite dramatic. So what happened to Ms. Triglioni? Well, the cross-cover resident who did the physical exam saw the patient and believed that she had a paradoxical embolus and a brainstem stroke. An MRI was ordered as well as a transthoracic echo to check for a patent foramen ovale. And the transthoracic echo was done first, and the primary team checked on the results and found them to be negative for a patent foramen ovale or evidence of right to left shunt. The resident checking the results called you and said, "Good news, Mrs. Triglioni does not have a paradoxical embolus." As you think about the resident's conclusion, you remember this course, and you're worried about jumping to the conclusion that a negative test rules out the disease. So you regroup and look at your data. The pretest probability you have shows that Mrs. Triglioni's possibility of having a paradoxical embolus is very likely. And the sensitivity and specificity of the transthoracic echo for paradoxical embolus you find in the literature is 60% and 99% respectively. So, first quiz of the day. Given the sensitivity and specificity of transthoracic echo, and using the evidence-based medicine heuristic we introduced last week, the result of a negative test for a patent foramen ovale would change our pretest probability of paradoxical embolus from very likely in Mrs. Triglioni to, number 1, very unlikely, as the resident says, Number 2, unlikely. Number 3, uncertain. Or number 4, likely. And of course, we said that the heuristic is able to move a diagnostic certainty down or up 1. So a negative test would move her from very unlikely to simply likely, not all the way down to unlikely. So if you were skeptical that the resident's conclusion was right, congratulations. That was, you're thinking in the right direction. So let's look at it from the Fagan nomogram. The likelihood ratios, again, is the likelihood that a test result comes from someone who has the disease rather than someone without the disease, whether it's positive or negative. In transthoracic echoes, likelihood ratio for patent foramen ovale is 67. So a positive result on the TTE is 67 times as likely to come from someone with a patent foramen ovale as it is to come from someone without a patent foramen ovale. Whereas a negative transthoracic echo is 0.3 times as likely to come from someone with a patent foramen ovale as compared to someone without. So let's put our nomogram to use. Pretest probability, 90%. Likelihood ratio, 67. Gives a post-test probability off the charts. So a positive test could truly rule in the disease in this test, using this test with a very high specificity. If that test was negative, however, 90% pretest probability, a very likely disease, a 0.3 likelihood ratio, which is actually pretty low, decreases our post-test probability only to 70%. So we moved from very likely to simply likely, as our heuristic predicted. So, Mrs. Triglioni is now seen by another team, and they reevaluate her, and one of the residents thinks that she might have benign positional vertigo and performs an Epley maneuver or a Dix-Hallpike maneuver. And I encourage you to look this up, but it's a maneuver in which you manipulate the head to see if you get results that are consistent with benign positional vertigo. Our pretest probability for benign positional vertigo, remember in our tiering, was a tier 3, so 20% or lower. And the sensitivity and specificity for the Epley maneuver is 75% and 75%, which sometimes happen. It's not common to see them identical, but sometimes that happens. So, second quiz of the day. Using the pretest probability of 20% with a sensitivity and specificity of 75 and 75% respectively, the post-test probability of BPV for a positive test is very likely, likely, uncertain, or unlikely. And the answer is 4, unlikely. If we consider 20% to be a very unlikely pretest probability, the most a positive test can increase it is to a level of unlikely. It certainly cannot make it very likely. Let's apply Mrs. Triglioni's Epley maneuver to our Fagan nomogram so we can confirm this and finish up with our confidence about the wisdom of her diagnosis. So we start with our pretest probability of 20%. And calculating a likelihood ratio with a sensitivity and specificity of 75% and 75%, we get a positive likelihood ratio of 3. See how much the lowered sensitivity affects this likelihood ratio positivity? And a negative likelihood ratio of 0.3. So again, applying our ruler to the Fagan nomogram, we start with a pretest probability of 20%, a likelihood ratio of 3, and we end up with a post-test probability of 40%. A negative likelihood ratio would move us down to a post-test probability of about 7%. So it's hard to conclude that she definitively has benign positional vertigo in this particular diagnostic strategy and set of circumstances.